The difference between the prognosis for newly diagnosed and relapsed refractory patients is such a moving target to me, because obviously our patients live much longer than we anticipated, 8 or 10 years ago. And with the advent of more and more new agents, we can see already that the outlook for somebody with their first relapse is much better than it used to be.
So in terms of symptomatic versus asymptomatic relapse, again, it depends of several factors. So if it's let's say 75 years old patient, retired in Florida, that is playing golf every day, and then during a routine CAT scan, I found that he has one lymph node in the axillary area, so probably I'm going to do radiation in that area. Of course, I do all the restaging, all the studies, and if I only one side, I will just do radiation oncology. And then I said, okay, go back, play golf. I will see you in 2 or 3 months, close follow-up. If it's a symptomatic relapse, it depends what type of symptoms the patient have. So, and if patient has, let's say, relapse, non-bulky disease, but it has a good performance status and is enjoying life, in some patients, I might do watchful waiting again. So it depends also what type of response I got. So let's say if I treat a patient with my chemo induction and then put it on maintenance and then the patient relapses, but he has a very good 2 or 3 or 4 years. If he relapses with little amount of disease, and so I might say, okay, let me do. So in other words, I am not in a hurry to treat that patient. Now, there are multiple clinical trials, and of course, our first recommendation was let's try to find a clinical trial in which you may fit. And those clinical trials could be a combination of the novel targeted agents, non-conventional chemotherapy agents that can be safely used in this, again, elderly patient population. So in terms of the geriatric assessment, I think it's extremely important in mantle cell lymphoma in particular, because we just said that this is a disease that affects elderly population. And probably in most of these patients, although we would like to cure them, so we are not there yet. So therefore, the first question that we need to ask is, what is the goal of my treatment? And my goal of the treatment is to control the disease, but with a good quality of life. So then we need tools like that geriatric assessment and other tools that are going to tell us, yes, I am inducing a great response with my treatment, but also keeping a good quality of life on these patients. So it's very, very important to keep that in mind when we make a decision in terms of treatment of mantle cell lymphoma. So what I tell my patients, and most of them are elderly, is my job is, I wish I can cure mantle cell lymphoma, but if I cannot, I want to make sure that your disease becomes chronic to the point that you will live longer, and then you are going to be able to see the new therapies that are coming at a very rapid pace. And as we are going to discuss probably later today, now we have not only 1, but up to 3 drugs of the same type. And what we are looking is which of these has less side effects that could fit my elderly patient better.